Good morning, everyone. Thank you for being here this morning. Today, we are going to take a look as a result of, I know, drum roll, please, we read the reports that people submit. At least in this committee, we do. We were taking a look at the most recent report, and it prompted us to want to talk with folks who have been involved to get updates on the Ethics Network and to also ask some questions because some of us have heard some feedback about the changes in the medical aid in dying bill and just, taking a broad look at access to and planning for end-of-life care and decision-making. So thank you all for being here. Have y'all, is Cindy, are you going to be up first?
I think if you want to talk about aid and dying, you might want to talk to the folks from Patient Choices first, because they probably will have the most up-to-date information. I have some, but theirs is probably more up-to-date.
Okay, all righty. So we want to talk about the whole thing. So why don't we, we'll start off with that then. Why don't we do a brief round of introductions? Because I think this is the first time this year for people to be here. And we have some new committee members from when we passed the law last biennium. So I'm Teresa Wood from Waterbury, and I also serve Bolton, Buellscore, and Huntington.
I'm Ray Garofano. I live in Essex, and I also represent Essex Junction.
Hey, I'm Jubilee McGill, and I'm from Bridport, and I represent Middlebury, New Haven, and Weybridge as well.
Good morning. My name is Zahn Eastis. I'm from Guilford, and I also represent Vernon.
Good morning. Doug Bishop. I represent Colchester's Chittenden 20 District.
Hi, good morning. Eric McGuire. I represent Rutland City.
Good morning. I'm Dan Noyes. I represent Woolkit, Hyde Park, Johnson, and Belvedere.
And Donahue from Northfield, also represent Berlin.
And Cindy will go right around the outside.
Sure. Cindy Brzezzi. I am the Assistant Director of the Vermont Ethics Network.
Teo?
Teo Jagar, a lobbyist with McCrasten Group.
Susan Aronoff, Senior Planner and Policy Analyst, Vermont Developmental Disabilities.
Allie Castillo, work for Home Health and Hospice.
And I'm Lori, Force Committee Assistant.
And now on screen.
Yeah, okay. I'm Betsy Walkerman, co-founder of Patient Choices Vermont and a board member.
And good morning, I'm Amy Bruce. I'm the relatively new Executive Director of Patient Choices Vermont.
Great. Thank you all for being here this morning. Why don't we start off with Betsy and Amy, and we're interested in, I guess, feedback that you have been hearing about the impact on Vermont healthcare providers and on access. From the information that we have reviewed, it looks like there's an increase in the utilization, or I don't say utilization, but application for maybe for access to this assistance, and just interested in your thoughts and overview about how you think things have gone in the last year or so.
Well, thank you. Yeah, we really appreciate the opportunity to be here and to meet with both people we've worked with for a long time in the past. So thank you to all of you, and to meet the new members of the committee. I think it would be helpful for me to just take 1 minute and just review the history of Act 39. Patient Choices Vermont was founded in 2002, and over the next 11 years, there was a broad discussion about the proposal to have a medical aid in dying law in Vermont. Act 39 was adopted in 2013. And at that time, Patient Choices Vermont pivoted to become an educational organization, recognizing that both families and patients and providers, both medical and hospice providers, wanted and would need ongoing support in terms of education and consultation in connection with end-of-life choice, whether it's medical aid in dying or other choices. So, yeah, and since 2015 to 2024 is when I have headed up the organization as president, both from a board perspective and operational perspective. And then I was very pleased that we could take the next step to preserve our longer term ability to provide stewardship for this law in Vermont and for people who choose to access it by bringing in Amy Bruce. If it's all right, I'd like to just ask Amy to just summarize where she came from and her position.
That'd be great.
Yeah. Good morning. Thanks, Betsy. I have spent the last 15 years or so working in end-of-life care and running community-based palliative care programs in Northern California and Maryland before I came here to Vermont last fall. I was in California working at the palliative care service when medical aid in dying was legalized in 2016 in California. So supported provider groups and the community and understanding what medical aid in dying offered, what the limitations of the law were, and how to develop policies and protocols to serve the patients and families, and also help medical provider groups, hospice organizations understand where, how they could best meet their patients' needs and also respect the autonomy of their providers. So that was my experience with medical aid in dying before coming here. And I really understand, my view is that medical aid in dying is a very important part of comprehensive end-of-life care. And that we're here to make sure that everyone understands all of their options and makes the right choice for them.
Yeah, so thanks for that opportunity to just provide a little more background. So for those who might be new to medical aid in dying, Act 39 allows an individual who is terminally ill and has a 6-month prognosis for their end of life to request terminal medication from their physician. They have to be able to self-administer the medication, and they have to be an adult, and they have to go through a process that includes 2 oral requests, 1 written request from their physician, and also review by a second physician. So it's a very set process that people have to go through in order to have the protection of Act 39 for medical aid in dying. Getting to the last year, 2 years, so I think, as you've seen, the numbers are growing of people who are using medical aid in dying, both Vermonters and now people from out of state. I think that's largely our sense is that it's largely because more people are aware, and that is partly because of a number of publicity through people's stories that have been published in both books and movies and extensive articles in some of the local papers in Vermont. And so more people are asking about it. The good news for Vermonters is that it used to be in 2013, 15, 17, 18, 20 even, the most common requests that we had on our medical aid in dying helpline was how do I find a doctor who will prescribe, from Vermonters. Over the past year, in 2024, we've received 0 of those requests. So that I would take that as very good news that people who are asking are finding their way if their doctor is not willing to prescribe to a doctor who is willing to prescribe. So I think access for Vermonters is really good. we offer coaching doctor to doctor for doctors who are prescribing for the first time. And while the law looks very cut and dried, you do step 1, you do step 2, you do step 3. There are many nuances that patients and doctors ask about in connection with how that process jives with what's actually going on for the patient in terms of when they want to make the decision, what they're able to do, whether they can swallow, whether they have other conditions that would affect their decision. And so providers really appreciate that kind of coaching. As you know, in the last session, it's now almost 2 years ago, the law was made consistent with the fact that our healthcare systems are really regional in nature, and that, for example, Vermont doctors often have patients from upstate New York, and they have some have patients from New Hampshire, and so the law is now available to people from out of state. So as you can imagine, people from other states that do not have medical aid in dying laws have been exploring, we think in pretty great numbers, the ability to come to Vermont for that choice. The actual number who have come is actually relatively low. I mean, we field quite a few requests every month. I think we're up to about 1,000 a year for people who are looking for information, and our website traffic after the passage of that law went up to 20-some thousand views per year, which was a huge jump. Our sense is that when people begin to understand the difficulties of traveling to Vermont to complete all aspects of the process, reality kind of sets in, and a lot of the coaching that we provide on the helpline really directs people to their local networks for both hospice and friend and family networks, because of the impracticality, or in some cases, people simply aren't going to qualify anyway. That being said, there have been, I would say, probably numbers in the dozens, low dozens, of people who have successfully come here. It's not easy for doctors and hospice organizations to serve those patients. And so many have limited the extent to which they will take patients from out of state solely for the purpose of medical aid in dying. I can get into that more. We've worked with both doctors and hospice organizations to help take some of the burden off of them by having what we call our Wayfinder network, which is a network of people who are mostly either death doulas or retired hospice volunteers or hospice staff who provide a lot of logistics and emotional support to people who are coming from out of state. And so the doctors who are prescribing for people from out of state are relying a great deal on this network of people that we launched 2 years ago.
Betsy,
Yeah,
can I just ask
let me pause there.
Yeah, I was going to say, let me just ask a couple of questions, because I think one of the important data points that you mentioned, which is actually really different from when we have been taking testimony on this subject, when we passed the update and then the previous action, was about the inquiries from people who needed to find the assistance of a physician, a healthcare provider who would provide them information, help them understand the process, and really just have discussions with them about what this all entailed. And so it's quite striking that, you haven't received any requests for information. It feels like what it tells me. I remember, hearing from Dr. Barnard, and she was, kind of like running herself ragged, really trying to accommodate, so many people's requests for information and potential eventual assistance. And so that seems to be a positive outcome of the increased awareness, is that more healthcare professionals are willing to have those discussions with people when they ask. And even if they're not willing to, be this prescribing authority, they're at least willing to be able to have the discussions and connect people with resources. I just want to make sure that I'm not making more out of the statement that you said than exists. But is that your sense about what is happening in the end of life and healthcare field?
I would say yes. You may want to hear from Dr. Barnard as well.
Yeah.
She still fields a tremendous number of calls, mainly from providers who are asking more nuanced questions about how the process works or a particular patient's situation, and does a lot of coaching. But I think the unknown is how many people are making their decisions without even knowing about the possibility of medical aid in dying.
Right. Yeah.
And we think that number is probably still pretty big.
Thank you. Go ahead, Representative Bishop.
On that point, if I understood correctly, you said that your best estimate of the number of folks from out of state who are utilizing the more recent change in the law that will allow folks, non-Vermonters, to do this. You put that number in the low dozens, but even though that number is relatively low, I'm curious, do you have a sense as to how they're getting connected? If they're not making inquiry of your organization, how are they getting connected with Vermont providers to wend their way through the process? I think some, you said maybe New Yorkers seeing Vermont doctors, New Hampshire folks, et cetera, but more broadly, can you address that question?
Yeah. So people who are looking at this option tend to be very resourceful, and they will call every palliative care department from the different medical institutions in the state. So they make lots of phone calls, and they also have had access to our Wayfinder network. And some of our Wayfinders do have working connections with doctors who have made room in their schedules to prescribe. So it's a fairly low number per prescriber, but so some of the people who come make those connections through our Wayfinders. Amy, do you have anything to add to that?
Based on what I've been hearing since I arrived in the last year, it does seem that there are more people prescribing for out-of-state patients throughout the state. I think in the past it was concentrated with one or two providers. And from what we're hearing now, because again, there isn't a publicly available list of physicians that are always willing to prescribe, their practice demands change over time. So that's not something that people want to publicize. But from what we hear from the Wayfinders and the other volunteers and hospice staff throughout the state, there does seem to be people available to prescribe throughout the state. Even for out-of-state patients, they might keep the numbers really low, 1 or 2 a month. But there does seem to be greater access than previously. And again, as Betsy said, having that volunteer that's willing to take a lot of the logistical planning and a lot of that ongoing communication with the patient and family off of the provider office really helps them, those providers, feel like, okay, I really can offer this service with that level of support.
Thank you.
That's an additional question.
Yes, go ahead.
So back to, and I'm new to the legislature, so while generally familiar with this existence of this option in Vermont, I'm not familiar with the details. You referenced it's for folks who may be terminally ill with a 6-month prognosis, and a prognosis can be very challenging to identify. So I'm curious how that sort of plays out, and does the fact that medical interventions may extend the prognosis, how does that play into the question of what the prognosis is? So any information on that front would be helpful.
Sure. Let me take a stab at that. So first of all, the 6-month prognosis, one of the reasons that timeline was chosen is that it's a very common prognosis that doctors make for other purposes as well, especially hospice. So in order for a patient to be admitted to hospice, they need a 6-month prognosis. So it's a very common evaluation that medical providers perform. That said, everybody recognizes that it can go one way or the other. People can die sooner than 6 months, or they may live longer, or they may come up with their condition may change. They may come up with treatments that would be acceptable to the patient, that would enable them to live longer. And but it does provide essentially. It provides a line that determines that medical aid in dying is being provided to people who, at some point in the near future, are going to be dying anyway. And I would also mention that even if there are treatments that could prolong a patient's life, we in Vermont have a patient rights law, and it is up to the patient to determine whether that's a treatment and the trade-offs of that treatment are something that they're willing to accept. So, so these are things that are determined, by the patient and the doctor in the course of their medical evaluation.
Thank you.
Thank you. Representative Eustis?
Thank you. Along these same lines, I'm just curious from a historical point of view, I guess. I get the notion of 6 months, but in my personal experience, I've been around a lot of people who spent much longer dying than a few months. And I wondered if had there ever been discussions, or what were the discussions like about, for instance, people with dementia? That kind of situation. Can you speak to that at all?
Yeah, I appreciate the question. Let me take it backwards. So the question of dementia, that's a very difficult situation that people deal with, especially those who are diagnosed early, like an early onset Alzheimer's type of prognosis. I'm not aware of any case like that where the person has qualified for medical aid in dying. Typically, those diagnoses are not terminal diagnoses within a 6-month period or anything identifiable, unless the patient has another terminal condition.
Sure.
And then once the patient has lost capacity to make the decision, they definitely are not eligible for medical aid in dying. It is one of the questions that we get very often from people who are concerned about their futures. But we explain what I've just related to dementia and Alzheimer's. There are if you look at the Department of Health reports on the data, it's very consistent that about 3/4 of the people using medical aid in dying have cancer of one kind or another. And that's because those are typically the conditions where people do get a 6-month prognosis while they still have mental capacity to make the decision and the ability to self-administer the medication. The other 25% are mostly neurological diseases where the patients also meet those qualifications. That being said, there are many conditions that are adjacent to those kinds of conditions where patients do qualify, where patients do not qualify. So for example, someone with ALS might very well qualify. Someone's with Parkinson's, it's rare that they'll qualify. So, so the law does make a line between those who will qualify and those who don't, that to many patients seems rather arbitrary, but we do our best to explain, and I know all the doctors do their best to explain what is available legally and what the other alternatives would be for those patients who do not qualify.
Thank you. So I interrupted you, Betsy. I'm just wondering if you had other comments that you wanted to make. I interrupted you with our sort of onslaught of questions.
Oh, that's quite all right. I mean, we're really here just to answer questions. So that's the number one priority. You know, so are there other questions now, or I do have a couple of other thoughts that I'm happy to share, but.
I had seen data, not from the health department, though. I was just looking for the most recent report, and that we haven't gotten one. So we're going to touch base with them, because I think it, it sort of provides a pre and post sort of comparison of what's happened in the since the law changed. So we'll want to get that. Anybody have any other questions before Betsy continues on? I'm not seeing any, Betsy. Thank you.
Okay, great. Thanks. Yeah, well, I do want to mention that, we as a nonprofit organization, one of the things that we do is to keep tabs on what's going on in other states. And there have been a number of changes in other states to things like the timeline and some details of the process for people to qualify for medical aid in dying. And we also continue to talk to providers to understand what's working well for them and what is difficult to manage in the process. And so I just wanted to let you know that although we don't have legislative proposals, haven't had this year, going forward, we may very well want to discuss some further changes to keep the law up to date and to make it efficient for both providers and patients and families.
Thank you. I appreciate that. Particularly since sort of to Representative Bishop's earlier question, medical technology is changing all the time, and this is a law that I think needs to kind of keep pace with those changes in the healthcare field and the practices that we learn from as we implement what we currently have for statute. So I appreciate the fact that we have folks like you that are sort of out there keeping track of, the feedback from healthcare providers, from people who are looking to have information, looking to be able to access this. And I think that, right now, at least we've tried to strike the balance between safety and intent and personal decision-making and healthcare practice. And I know it's been a balance that has been, hotly debated when the law first came into being. So, and I think that we've done, a good job at trying to make sure that we are addressing things as they change. So I appreciate the fact that you're keeping an eye out for that, and appreciate you both being here. And it's nice to meet you, Amy. Representative Bishop.
Two additional questions. One would relate to the requirement for self-administration. Is that in place due more to ensuring the self-determination of the individual going through the process, or is it relate to potential criminal liability if others were involved in the process? That's the first question.
Yes, it's in place to, as the final act of the person that shows that they're making their own decision.
The other question, oh, I'm
Go
sorry,
ahead.
go right ahead.
The law itself provides both criminal and civil liability protections for the medical providers involved, as long as the process and qualifications are followed.
The second question, you indicated part of your work of your organization is to keep in touch with providers for feedback, concerns, obstacles, thoughts on the law. You also indicated you didn't have any specific legislative proposals, but is there anything that's consistent enough in those conversations with providers that you think warrants sharing with us about what you're hearing in the field?
Yeah, I think I think it's time. It'll be time probably next fall or early next year to share a more comprehensive view. Because we've been expanding the number of people number of providers that we're talking to on a regular basis, and we want to make sure that we have a really clear set of recommendations. But I think you can expect them to relate mostly to the process.
Thank you.
Thank you.
And we have one final question from Representative Garofano.
Thank you. Representative Bishop's question made me think of a question. I wonder if you know if any states are moving away from that self-administration to have a physician, either a volunteer, or if everything's been documented. I know other countries have processes in place where because thinking about someone who's really frail and maybe older and really ill may not be able to self-administer at the very end of their life. So didn't know if any states are moving that direction, or is that not a reality in this country?
Yeah, not to my knowledge. Amy, have you heard anything?
No, I haven't. I think people see that as a pretty strong, distinguishing line between the United States practice and what is available in other countries.
Thank you.
Yeah.
Thank
I just
you.
want to add that, if at any time any of you or family members or any of your constituents have questions or issues related to end-of-life choice and medical aid in dying, we're here for you.
Thank you. I appreciate that very much. Thank you both for being here, and thank you for the update. And we look forward to continuing discussions as this whole practice evolves over time. So thanks very much for the updates.
Great. We appreciate the opportunity.
Good
Okay.
to meet you all.
You as well. Cindy, would you join us? First off, thanks for a very comprehensive annual report.
Sure.
It's always very helpful to see all that you've been up to in the course of the last over the last year, and appreciate everything that you're doing. So really, we just wanted to sort of hear an update from you in terms of, what are sort of emerging issues, things that you think may need attention in the future, things that you're hearing out there. I think Vermont is still lagging behind in terms of, thank you, still lagging behind in terms of access, not access necessarily, but use of more end of life care in terms of hospice care and things like that. Advanced directives, we know there's always work to be done in that regard. So thank you for being here, and happy to have you, and thank you for your annual report.
Sure. Thanks for having me. I wear a number of hats in addition to being the director and ethicist at the Vermont Ethics Network. I also work on staff part-time at UVM Medical Center. I'm one of the ethicists on staff there. I chair the ethics committee for the Department of Disabilities, Aging, and Independent Living. I direct the statewide task force on palliative care. And more recently, I'm now one of the co-chairs of the Academy of Aid in Dying, which is a national ethics committee that's available to all states who have legalized medical aid in dying. So I co-chair that committee, and we respond to ethics questions that come from across the country from clinicians or organizations who have ethics questions surrounding the practice of medical aid in dying. So I've been doing that work for a couple of years now as well. So those are just, I'm around doing different things. So yeah, in terms of, I think what we're the Ethics Network's most well known for, of course, is advanced directives and portable medical orders and doing education for the community, for organizations and clinicians around how do people plan for the what ifs that can happen across the lifespan when they lack capacity and there's no way for clinicians to ask them directly what matters most and how to take good care of them and make sure the treatment that they're getting aligns with what's their priorities are. We don't really have any other tool other than advanced directives and portable medical orders to try to learn more about what matters to these individuals and who they trust to sort of speak for them if they can't speak for themselves. So that work is ongoing, and we are seeing record numbers of people completing advanced directives and submitting them to the Vermont Advanced Directive Registry. We're upwards of 55,000 Vermonters now who have documents in the registry, which is a pretty high percentage compared to other states. And that's only the quantitative number that we can measure, which is people who sent their document to the registry. If they may have it in their home, they may have it with their attorney. I hope they don't have it in their safety deposit box, but they may have these documents. It's just, we don't know about them, but we can measure what's in the registry. In the last 6 months, we responded to over 1,200 calls from the community. Those aren't all about, my office does. Those aren't all about advanced directives. Some of them are about medical aid in dying. Some of them are about thorny ethics questions or guardianship. So we're kind of the go-to place for, I don't know what to do. Those are the calls we get from the community as well as from organizations and healthcare providers.
Cindy, do you get, well, you just said, and healthcare providers. And I know you provide an education series and, sponsor workshops and stuff for providers. I know in the past we've talked about that it is sometimes difficult for primary care practitioners to engage in the conversations with individuals on their patient caseload, just about, regardless of age really, about the need for things like advanced directives. And are you finding that the healthcare professionals are becoming more engaged in that work or more comfortable with that work?
I think so. I mean, I think what we're recognizing is not everybody needs to have a very lengthy discussion about end of life. Some people do, depending on where they are, what's going on with their health. But everybody needs to talk about, what if something unexpected happens? Who makes decisions for you? We are starting to see more and more practices sort of integrate that into their just regular work.
Mm-hmm.
As people come in for their annual visit, now CMS requires you need to ask people if they have an advanced directive. So that has driven more of that standardization and building that into the workflow. Some family medicine practices have also integrated just the appointment of a healthcare agent as part of their workflow to make sure all of their adult patients who have who are their own decision makers, so not people who are under medical guardianship, but any adult who's their own decision maker, that we're asking them that question and promoting them to name a healthcare agent. So we're definitely seeing increases, I think, across the board. I think it's still a challenge to have, in-depth end-of-life conversations. Often those are happening in the hospital after a recent event where someone can sit with them and really talk about what's just happened, what the future is going to look like, and maybe what they need to start thinking about. I think that's happening in some primary care practices. I think they're having a lot of case management and social workers initiating some of these conversations as like the first step, and then having maybe just the more narrow medical kind of alignment conversation with the clinician so that they can kind of divide and conquer, if you will, and give people support. And we certainly help people complete advanced directives at our office. So we have people calling all the time to ask us to walk through the document with them. And we do a lot of training in the community for nursing case managers, social work case managers, the area agencies on aging, how they can make sure that they're feeling really comfortable with these forms and tools and can have these, at least these initial conversations with patients to get the ball rolling. But as you all know, this is a process. It's not really a one and done because goals and values change as your healthcare changes and your priorities change and your people, like the people in your life changes.
Yeah.
And so these are things that need to be revisited, and questions and conversations maybe get more in depth as time goes on. But it's nice to see people starting to at least have the low risk kind of entry level conversation about who's your decision maker, because you don't need to be dying to need to have a decision maker.
Right.
Unexpected things happen all the time to healthy people, young people. And so that, I think, starts to normalize that this is just part of good person-centered care.
And I didn't realize the requirement that CMS has. Is that for people Medicare age and above, or is that just
Everyone.
really?
As part of your coming into the office, it's standard. So when you go for your annual wellness check, somebody should say, do you have an advanced directive?
Mm.
Whether they ask you, do you have a copy of it? Is it in the registry? Do we have a copy of it? That still remains to be seen. I certainly have pushed a little bit in my own visits with my PCP and saying, well, do you want to know what it says? Do you want to know where it is? And they're always like, and I feel a little bad because I'm obviously a bit of a ringer. So definitely just prompting people to think more than just checking the box, but also to make sure they have that information and we can retrieve it when we need it. Because let's not forget, we're not looking at these unless we can't talk directly to the patient. So we need to make sure it's all set up before that happens, if it happens.
Yeah, Representative Noyes.
Thank you. Is there a way to check? Like, I did one. I have no idea if it's in the database. Is there a way to
Yeah.
if it's in there?
So two things. If you registered your document, you should have received a letter from the Vermont Advanced Directive Registry saying, yay, you put your document in the registry. Here's a wallet ID card, and it gives you the instructions for how to log in and look at your document.
Okay.
If you don't have anything like that, you can certainly call our office. We do this all the time, and we say, I think I don't have anything. Am I registered? And we can check.
Yeah.
Your healthcare provider can probably also check. Every hospital in Vermont is an authorized user of the registry. Many private, primary care offices are also registered users of the registry, so they can log in. All they need is your last name and date of birth if they're an authorized user.
Yeah.
If you're not an authorized user, you can't just log into the registry. You'd have to have an account and that wallet ID card, or you'd have to be an authorized user in order to get that access.
Yeah.
But we at the Ethics Network have that access because we have taken over, as you read in the report, we have taken over the responsibility of ensuring that Vermonters who don't have computers, who can't upload documents for themselves, can still have access to the registry. So we've had to hire a full-time staff person to basically scan and upload and create accounts for all the Vermonters who aren't able to do it themselves.
I want to say thank you for doing that.
Yeah.
So I hear all the time from people who say, well, what if I don't have a computer? What if I don't know how to do that? Or, so I appreciate the accommodation. I mean, I really could look at that as an accommodation for people who, there's generational differences that happen. And I think that's important to make it continue to be accessible or increase accessibility for people who don't have ready access to a computer or ability.
Scanners. Uploading their document. There's lots of reasons. The registry, which is the company that owns the registry where we pay for space for Vermonters, is based in New Jersey. So previously you sent your documents to New Jersey and they did all of this for you. That company changed their business model and now they only do user upload. So you'd have to be able to upload your own document. And we just said, we're an ethics organization. So from a justice perspective, a fairness, equity perspective, that just wasn't going to fly. So we worked with the Department of Health to come up with a plan to ensure that people that have maybe different levels of computer literacy, different levels of access. I mean, let's be honest, even Wi-Fi can make it a challenge for people to be able to do something like that. So we have taken on that responsibility. We do have a lot of people who are uploading their own documents though, because they can. But we still want to make sure that anybody who wants to utilize the registry has access.
Good. I appreciate that. Some of the things that you were highlighting in your report, including the like Center for Vermont Home Health and Hospice expansion of their palliative care services. Is that something that's available with all the other home health agencies?
No.
Okay.
It's very unique there. And I would say if there's a need, and I think if you looked at the UVM report from Steve Burns submitted that, he's the new director of palliative medicine at UVM Medical Center, and is that community-based palliative care continues to be a gap in our service profile, I would say, for people who could benefit from those types of services, who are living with serious life-limiting disease, who don't yet qualify for hospice. They may still be pursuing disease-modifying therapies, but access to that type of service in the community continues to remain challenging. Center of Vermont has a program that Dr. Kelly Elwell is doing. It's unique. I think Diana Barnard many years ago had a similar type of program where she and her partner used to only provide services to folks in their place of residence. So they went to all of their patients, but that's actually not a model that is replicated because the funding for it is just difficult.
So I'm seeing that one of the things is developing increased support for this through Medicaid for people on Medicaid.
Yeah.
And you're gonna have to refresh my memory about how much, at least at the current time, that Medicare, it's a covered service for Medicare.
It's covered.
Right.
I mean, I think the best person to talk to about her model is Kelly, Dr. Kelly Elwell directly, because she's the one that's doing it and has come up with the structure for how she's billing for it. She can bill for symptom management in the outpatient setting. She can bill, and I think it's Medicare B. I think she put some of it in there, but that's outside of my ethics space. Once we get into billing, it's outside my scope. But I will say that she has developed some structure for that. But I also think we don't have a ton of palliative care providers who can work in the community, right? So it's about workforce, which I know we're doing a lot to do workforce development in general in healthcare. But I would say that is a gap, is community-based access to palliative care services, largely because some of the funding structures make it more challenging.
Yeah. So in something I guess that I wasn't aware of is it looks, in talking with the Department of Vermont Health Access, I guess I did make the assumption that it's more developed than it appears to be. It sounds like there's progress being made.
There is progress.
But so that it's actually surprising. So then it shouldn't be surprising to us that people aren't utilizing it as much as would be really beneficial to them.
Yeah, I think there is work being done to make sure people are aware of those, like the codes, the CPT codes that you use to bill for things. For a long time, I think even the Department of Vermont Health Access, they didn't have it noted that you could bill for advanced care planning conversations, which of course you've been able to do now since I think 2018. And so they've upgraded their workflows and their documentation so that now people can bill for those conversations, similar to what Dr. Elwell is doing. She's billing also for doing goals of care conversations with people in the community. So yeah, there's probably more work that needs to be done on that front. And I think people like Kelly can probably give you more specifics about where they see the greatest opportunities to expand there. But I will say that in general, community-based palliative care continues to be an area of where we're deficit. Do you know what I mean? I don't think we're unique. I don't think Vermont is particularly unique in that way. I think that's just a problem.
Yeah.
originally, I think, driven by some of the home, it was lumped in with home care, and with home care, you need to be homebound, and so many of these people aren't homebound, so there was a lot of barriers.
And I mean, even now, some of the care is provided by home health agencies, and so people have that.
If they meet those
If they meet
criteria,
those
yeah.
criteria, yeah, but they think that that's the only way that they can receive it.
And you need a skilled nursing need too to qualify for home care. And so a lot of these folks, they're actually doing well, but they would probably be feeling better and doing even better if they had that comprehensive support that palliative care services can provide.
Yeah.
And they can get it in the hospital. And we're pretty good. I think we do really well across the state in terms of hospital-based access to those kinds of services. I think where it tends to fall apart a little bit, depending on where you are in the state, is when you get discharged. What level, like if you're here in Southern Vermont, you may have more access because they have a program. But if you're in the Northeast Kingdom or someplace else, you may not have as much of an access. One thing I did want to raise, just because I know you spent a lot of time talking about medical aid in dying already, is, in my work, I do ethics consultation as well. So I do that at UVM on staff, but I also do that for all the other hospitals in the state. Almost all of our hospitals have ethics committees, but they don't have trained ethicists. So my organization does a lot of work to train those ethics committees so they can respond to a pretty good chunk of the ethics questions that come along, because most of them are similar. And sometimes it gets super complicated. And so they call me and I do ethics consultation directly for those facilities. And this year, I think as it relates to the change in Vermont's law around medical aid in dying, I've received more ethics consults from hospice agencies who are struggling with the influx of out-of-state patients who are seeking to access medical aid in dying, who have very, very, very short lengths of stay, 24 to 48 hours, which is, as you can imagine, pretty hard for a hospice organ. I mean, they do it obviously when it's a unpredictable, people you don't get to pick your illness, and mostly you don't always get to pick when you die or how you die. But for people who are choosing medical aid in dying, there is some predictability about what they're going to do. And so to have people come from out of state who are only here for a very short stay is pretty challenging for hospice organizations. And my initial thought was that this was more of a financial issue. But with the hospice agencies I've spoken to, it's not about the money. It's about hospice is a philosophy of care. It's a way of caring for people at the end of their life. The people who do this work are a special type of person who really can sit with people in this most vulnerable and intimate time in their life and develop relationships and connections and support them and their families through the dying process. When that is cut very short to less than 48 hours, they can't do what is the philosophy of hospice. And they only are there to pronounce the death. And that has been morally distressing for many of these hospice nurses, as it was relayed to me in several of these ethics consults. That's the concern. And so I think, hence the reason why we're starting to see some parameters, which I know certainly in the ethics consults I've done, I think is ethically appropriate. Hospice isn't a death pronouncing service. It is something that they do as part of their comprehensive, service, but it's not the only thing that they do. And so I think it's reasonable to set some parameters that are similar to how they would for any other patient who's utilizing hospice services, so that they can actually do the work that kind of feeds their soul in terms of caring for these people at this very intimate time of their life. And that's probably been one of the bigger challenges that has emerged that I don't think anybody really necessarily anticipated, but it is worth acknowledging because it has caused distress for many of these agencies and their staff who we need to care for our aging population. So I just wanted to raise that. And I think we're working, Patient Choices is working, my office is working with these agencies and with the prescribers to sort of help them understand what hospice does, and so that we can optimize what they're there to do for supporting patients and families in a way that allows them to keep wanting to go back to work every day.
Yeah, and it's one of the reasons that I asked the question about providers earlier is because I had heard from a home health agency in southern Vermont about increased access or desire to access their services under hospice for this. So Representative Donahue has a question.
Yeah, totally different subject. Really a question about some of the scope of your work. I happened to be asked to do a seminar at UVM on research ethics and consent. And in delving into some of the background, it appears to me that some of our law and advance directives and the advisory pieces of the then advance directive sample and so forth had some inconsistencies with our anatomical gift laws. And is Venn involved at all with the anatomical gift program, or is it just advanced directives?
Well, I mean, we certainly do get questions about people who are seeking to donate for anatomical gifts, and they can make that, they can alert whoever's looking at their advanced directive that they have done this, but they can't actually donate through the advanced directive because they need to make all those arrangements in advance with whatever institution they're going to be donating their body to. Are you talking more about?
Yeah, but I mean, that's institutional policy. That's not the law or the
Right.
advanced directive law that says you have to have done that.
Right.
It's just that you won't have anybody who wants to take it if you haven't planned.
If you haven't made a plan, exactly. So that's pretty standard with all the institutions. Yeah, so we just educate people about, they can certainly indicate on their advanced directive if they want to do organ donation, and they can say if they've made arrangements already for an anatomical gift to a particular institution. We also tell people that if they want to be a registered organ donor, that they still need to go through the process of registering, because the advanced directive alone doesn't put you in the registry, the organ donor registry. That is connected through the DMV. So, or you can do it yourself. If you don't have a driver's license, you could go online and register yourself. So we still alert people to the fact that the advanced directive registry is separate from the organ donor registry.
Right, and you're not involved with that piece. So if there are
Not organ donor registry.
inconsistencies between those, that wouldn't be something you'd, okay.
No,
Thanks.
no problem.
Great. Cindy, we sort of started asking a bunch of questions. Wasn't sure if you were done with your comments or if you had other comments you wanted to make.
No, I think that's it. Just really very always appreciative and grateful of the work of this committee over the years and how supportive you've been of changes that we have proposed when we've identified barriers or gaps in services that we think a legislative fix will help to solve. We really are grateful and appreciative of all the support we've had over the years. We try not to come all too frequently, or we try to wait until we have a number of things that all need to be addressed and to do it all at once, to try to minimize sort of the work here and that we can be thinking more proactively. I don't think there's one little issue I don't even know if it's related to advanced directives that we're still trying to figure out whether or not we need a legislative solution for, and that pertains to treatment over objection. We are getting an increasing number of calls from the community about Ulysses clauses. Yes, we're doing a lot more training on that particular provision. It's connected to dementia. It's connected to people not always wanting to die the way a dementia diagnosis may progress to death, which is why I think Betsy's and Amy's organization, they're getting calls from people who want to try to figure out, can I do this if I have dementia, use medical aid in dying, which of course they can't, and they can't anywhere. It's not unique to Vermont. It's the capacity piece that's critical there. And so, but they're still dissatisfied with what the outcome is going to be from their dementia. And so they're exploring things like stopping eating and drinking as a way to hasten death when they're at the particular stage. They can do that much earlier in their diagnosis before they lose capacity through a process of voluntarily stopping eating and drinking. But in order to voluntarily do that, you have to have capacity and be able to operationalize that plan yourself. The other one is trying to endorse your agent to have food withheld, not feeding tube, but the spoon feeding piece, to not do that when your disease reaches a certain point at the very end stage, so that instead, we're not really prolonging life at that point, we're prolonging dying. And people are saying, I don't want you to prolong my dying, just stop feeding me. And it's really not the feeding that's the issue, it's the hydration. And so we're getting a lot more calls about that.
Because if the person who
Changes their mind.
it says, I'm really thirsty, I want something, when they don't have capacity
Right.
any longer, despite having wanted, then you've got a
Because you retain
conflict.
the right to refuse,
Right.
even when you lack decision-making
Unless
capacity.
you've done a Ulysses class.
Unless you've done a Ulysses clause. So we're seeing of an influx, I would say, of people asking about, how do I do this? How do I make my clause specific enough to comply with the statutory requirements? But also to give my family, because nobody's disease follows this. We were talking about prognosis earlier. It's a difficult thing, right? So that becomes a challenge. So we're seeing a lot more of that. And then the issue of treating people who are not dying, but treating people over their objection when they don't meet the statutory framework relative to doing so within that 24-hour limit. And we don't have any mechanism in Vermont to hold people in the hospital who are unsafe, who are not psychiatric. We don't have a medical hold provision. We have a very clear one for psychiatric illness. There's an emergency evaluation, there's 72 hours, there's like a very, very clear guidance for how to do that when the reason for the lack of safety is psychiatric in nature. We don't have a similar pathway when the reason is medical.
And there's a different reason for lack of capacity.
And there's a
Non-psychiatric.
non-psychiatric reason. So think about dementia, think about delirium, all kinds of things. And if they're refusing and they don't meet that emergency threshold to treat,
And they're demanding to leave.
and
the
they're
hospital,
demanding to leave,
even though they have dementia and lack of capacity.
and there's a misconception in the community that hospitals have some superpower to just hold people and incarcerate them in the hospital indefinitely, and they actually don't have any legal authority to do it. So I think that's an emerging area that's causing a lot of angst and frustration for families, because they're like, what do you mean?
They just have to go to court to be able to do it.
To get a guardianship, and that doesn't happen overnight. And meanwhile, you've got a person that probably does need a higher level of support and supervision, but hospitals can't just hang on to them. They certainly can't lay hands on them and give them emergency meds and restrain them. Like it gets messy and complicated. And so I don't know what that would look like, but I know that it's ramping up as an area of need. And I do think there's no amount of education. We do all the education for redirecting, trying to, persuade, encourage, like all the things that are non-coercive to try to get someone to just go along and not refuse. And we have some pretty skilled nurses who suddenly will just say, your room's ready. And all of a sudden this person will just go along, which is wonderful when they're not refusing, but that's not always the case. And so it would be nice to have at least some legal parameters to do this for safety. And I don't know if we can accomplish that without a legislative fix, but we're not there yet, but that's probably something kind of on the horizon that we're thinking about.
Same gap in terms of the growing elderly and dementia and so forth. We have the same gap in criminal law because you would be found not guilty by reason of mental defect if it's because of dementia. But unlike any other kind of not guilty by reason of, there is no ability to supervise or do anything with that person.
Yeah, I mean, I
the
think
same
you're
issue, yeah.
raising an overlay of an older population and the advances in medical treatment that have people alive for longer periods of time in this state of reduced capacity. And all these other issues that crop up as a result of that. And so it's kind of like, thinking about, well, I mean, it's part of our state plan on aging and the issues that arise in that and, taking a look at that. But
So that may be,
Yeah,
on the future,
unfortunately, we
yeah.
end up only responding either of those examples after some crisis. We
Yeah.
don't plan ahead when we know it's gonna come, but when we have somebody who leaves a hospital and dies on the street, there'll be an uproar.
right.
The hospitals will be being screamed at and they'll say we can't do anything, and then the legislature will.
So I think we're trying to be proactive with
Yeah.
using the tools we have.
Yeah.
And, you know, anticipating, because you can't anticipate if your dementia is gonna come with behavioral disturbance, which is really the one that's the trigger.
Mhm.
So they end up with an altered mental status in the hospital, but once that, it just becomes really thorny.
Mhm.
And I think we're trying to strike a balance between bodily integrity, patients' rights, individual rights, freedoms, and not being overly paternalistic by just, you know, doing things to people that they don't understand.
Yeah.
But we also know that there is some real risk and safety here and harm that's happening for someone who's that dysregulated due to a failing brain because of a neurologic disease that we can't fix, we can't cure.
We can also take them into protective custody if it's because of drugs or alcohol, but we can't if they're wandering the streets because of dementia.
Yeah. and-
Yeah, I think there's a lot of sort of overarching issues around the reduction in mental capacity as people age, and they're being impacted by lots of different things in our environment. I mean, you know, there's a lot of overlays to it. So we look forward as you think about these issues, because you're our expert in the field, carrying this, you know, weight on your shoulders and helping to help us think about what might be needed in the future. So we appreciate that.
Yeah, this is really my number one ethics consult that I get,
Yeah.
which is that, you know, it used to be, can we withdraw this or do that? That's like everyone understands now, but this is the most frequent call that we get. Can we treat this person who's refusing? Can we hold this person who's refusing when they don't meet the emergency threshold standard within the statute? Very, very challenging.
Yeah.
So just on your radar screen.
Yeah, no, it's helpful. It's helpful to know what might be on the radar screen, and appreciate the heads up about that as we sort of think about, you know, what we were just talking about yesterday, a long-term care trust fund and the creation of that, and trying to figure out how do we help pay for the supportive services that people are going to need in the future, and without being over reliant on Medicaid and Medicare to whatever extent either of those exist in the future for such things. So trying to help people plan for the future is not always something that people think about, to be honest with you. Yeah.
No, we still do a lot of managing by crisis. That's pretty much how things happen. And I understand it, you know, but I am seeing a shift in the last, 4 or 5 years. I think COVID, actually, if there's a silver lining to COVID, it definitely prompted people to start thinking about the unexpected.
Mm-hmm.
And since then, that's when we've really seen a significant increase in people wanting to do advanced directives, wanting to put some plans in place for themselves.
Yeah.
So that's probably a good thing.
Yeah.
But we're continuing to forge ahead.
Thank you so much for being here today, Cindy. We really appreciate it. And we look forward to hearing more from you in the future as things evolve, for sure.
Well, don't hesitate to reach out if you have any questions. And if you need to know if your document's in the registry, you can call our office and we'll check.
It was there.
And it's
So thank you for the reminder.
Yeah, I did get a reminder letter last year, so I need to check, because I was getting it every year.
So I should have said, it was easy, it was fine for the state to be mailing hard copy letters when we had 7,000, 10,000 people in the registry. When you get upwards of 50, 60,000 people mailing out that quantity of letters every single year became a real cost nightmare. So if you have an email address, you will get in your account, you'll get an annual email reminder.
Yeah, which I don't get, and maybe that doesn't, I don't know. I have to look.
But you can
into it.
add an email address now to your account, and then you'll start getting reminders from them annually. But we had to, for cost purposes, we had to no longer mail just a letter that says, hey, your documents.
That's a good problem.
Right.
In terms of mine.
Yes.
You know, that's a good thing.
That's what we were hoping for, right? That people would use.
Yeah.
Thank you all.
And a reminder to people, if you haven't done one, check out the Vermont Ethics Network. Yes.
We used to do
Reminder.
Yeah.
Anne would be like, raise your hand.
Excellent. Good work.
Yes.
So a little little breaking news that.
What?
Motion, Madai was just released by the
Oh,
wow.
in Burlington. Of
Good.
course, the feds will appeal it, but in the
Yeah.
meantime,
Yeah.
he's free.
Thanks, James.
So
Hi, how are you? We're just like transitioning between witnesses here.
Sure.
Come on in.
Would it be all right? Julie Holbert is my other board member. Yeah, and she actually is kind of our, because it's a 3-member board, we can't really talk to each other outside of an open meeting.
Yeah.
She takes the lead. We kind of split up policy areas, and she takes the lead on public health issues.
Okay.
And we have a little history.
Oh,
I was a temp employee
oh,
and they sent me to her office. And now look at you with the ladies.
Are three sitting here, or just two?
Just two.
Okay. I'll make you space.
Johnson, just like you. Julie, and she went to Johnson.
Yeah.
Right, your wife spoke at commencement last year.
Mhm.
Nice.
You were in it?
You have a connection. Yes.
I'm a Johnson grad too.
My son went to play soccer for Johnson.
Yeah.
So many games. Before you start then, we're trying to do an alumni mixer for all of the Vermont State Universities in Barville in June.
Yeah.
Okay.
Well,
I might still be.
Okay, so over to Barville. Okay.
So we are now switching topics. And Amy and Betsy, you're welcome to stay on if you want. We're talking cannabis now, so you're welcome to stay on, but I just wanted to let you know that we're switching topics. So welcome.
Well, thank you.
All right, take care.
Bye.
Okay.
So we've been reviewing reports in this committee, reports submitted to the committee, and the report that y'all submitted in November was one of the things that popped up for us, and are looking at the aspects of it that pertain to how we deal with medical cannabis. I think that, I think when we were talking about this last session, there was some discussion about, we're going to continue to do this like one-off, we're going to continue to do this. Does there even still need to be, a separate statute regarding medical? And I think we kind of, at least last year, came to the conclusion that, yes, we still need that. But we're looking for, what we're looking kind of to do is to tee up for next year, to look at potential legislative changes that might be something that we should be considering. So this is your all first time here. We've got a bunch of different committee members. So we're going to do a brief round of introductions. Teresa Wood from Waterbury. I also serve Bolton, Beal Score, and Huntington.
Ann Donahue, Northfield, also serve Berlin.
Good morning, Dan Noyes, represent Wolcott, Hyde Park, Johnson, and Belvedere.
Brenda Steady, East Milton, Westford.
Doug Bishop, Colchester's Chittenden 20 District.
I, Todd Gilson, represent Brandon Forestdale.
Hi, I'm Zon Eastis. I live in Guilford and I represent also Vernon.
Hello, I'm Esme Cole of Hartford.
Hey, Julie McGill, I'm from Bridport and also represent Middlebury, New Haven, Braintree.
Hi, Ray Garofano. I live in Essex. I also represent Essex Junction.
Lori Morse, committee assistant.
And back around to Jenny.
Virginia Renfrew, that's Renfrew Consulting.
So welcome. You can introduce yourselves for the record.
Sure. Thank you. Thank you for that. James Pepper. I'm the chair of the Cannabis Control Board, and I'm joined by
Julie Hilbert, another commissioner on the board.
and we're part of the inaugural commissioners as well. We've been there since the beginning.
Oh.
So I'm here today to discuss the report that was required under Act 166. But of course, I'm happy to discuss any issues outside of that report, or if you care about the adult use program or what's happening federally, happy to answer any questions that come up. I did want to acknowledge at the outset that there's kind of an inherent dissonance with the medical program because cannabis is a scheduled substance, Schedule I controlled substance. federally, which by definition means it has no accepted medical uses in the United States. That's, you know, I mentioned the dissonance because there are 39 states that have medical programs. And there's over 6 million registered patients in the country, and there's 30,000 registered healthcare professionals that can recommend cannabis. So, but, you know, it just means that, you know, there's no FDA involved in this industry. There's no kind of big pharma or anything along those lines. And there's not a lot of research being done as a result of this Schedule I status. So it's kind of a chicken and the egg situation. There are very likely medical applications for cannabis. In fact, the prior FDA acknowledged that cannabis can be used for pain relief, appetite stimulation for, you know, people with cancer particularly, and nausea. That's why they recommended it be Schedule III. But because of the Schedule I status, it's very hard for a research institution to even possess cannabis, let alone study it on humans or create kind of randomized trials. Okay, so turning to the report though, do you want me to pull it up or is it?
Actually, since people probably aren't looking at it, that would be great. Why don't you go ahead and pull it up?
Okay, and I got to just join.
Lori will give you access here in a second.
Laura, do you remember if you sent me the link already?
No, I'm
Okay.
getting that now.
Okay,
When you said you were coming in presentations.
okay.
Zoom is not our wheelhouse. We all operate in teams. It's a education.
For us too, when we have to go to Teams.
Yeah, all the time.
If you go to the judiciary, it's WebEx, so
I
there's
didn't.
no consistency, you know?
Well, and then the other day I was in something and it was Google Meet and I'm like, that's my least favorite out of all of them. Google Meet, least favorite. So all you Google software engineers out there, you can do better.
You have the resources,
That's
Google.
right. You got the resources, you can do better.
The link is just loading.
And if you want to follow along on your personal device, you can check under our reports and resources under cannabis.
Oh, is that where it is?
Yes.
Okay. That's why I couldn't find it.
Share screen.
There you go.
All right. So I'm gonna go straight to. There we go. Okay. Straight to slide 4. So, oops. Sorry. So slide 4. You can see here just the kind of the report requirements, the stakeholder group that was formed, the membership of that, the topics we were asked to examine. You know, I think generally speaking, as you know, federal cannabis is illegal federally, so the states have a tremendous amount of latitude to decide how both their adult use and medical use systems look. You know, who qualifies as a patient, the role of healthcare professionals in that kind of decision, what types of products and services can be afforded. Everything can be kind of, you know, unique here. And that's why you typically have a lot of advocacy for this program, you know, to make changes to it. And you often ask us to kind of get together with these folks, generally speaking, to propose changes. So it's really hard to kind of understand the changes without getting a little bit of history here. I know a lot.
That was actually really helpful, James. It was helpful to have that sort of like list of all the different changes that have happened.
Yeah, exactly. And I know many people in this committee have been deeply involved with this issue for a long time. So I'm sorry if this is redundant at all, but this is the basic kind of time frame.
It's a good background.
Yeah.
In background, I, of course, will vociferously object to the wording of the 2004 because we did not legalize medical cannabis at that time, but I won't debate that.
Okay, yeah, I'm happy to, for the next go round, change that. It was a therapeutic, cannabis for therapeutic uses? or-
No,
No.
it was use of cannabis for symptom relief.
Symptom relief, okay.
It was actually non-prosecution for purpose of symptom relief for,
Right. And so there's no brick and mortar dispensaries at that point. It was a patient caregiver model. You qualify as a patient and you could home grow for yourself.
and it still wasn't legal.
Right.
It was just a commitment that we wouldn't prosecute you.
Right.
Right. And so I think the two dates that you may want to focus in on here, 2018 and 2022, because on the next slide, you see those are two inflection points on the kind of patient drop off. We had the kind of high water mark in 2017 pre-home grow when the medical program was the only avenue to get legal weed, legal cannabis. And as soon as you did home grow within a year, you see a significant drop off in the number of patients. And then that trend is accelerating now. So then what's going on is that the economies of scale of owning a brick and mortar medical dispensary and, non-medical patients are not allowed to enter those. So they can only serve the kind of ever dwindling number of patients is that they're not matching up. The business model doesn't work anymore. So we've seen at the writing of this report, we had 2 of the 6 that existed close. We're down to just the top 2, the Montpelier Alliance Grassroots. A new one opened up, but it is one of these integrated licensees opened up, but it's co-located with their adult use. So it's not a standalone brick and mortar.
So the only standalone ones for medical cannabis are the top 2 now?
That's right.
Okay.
And my guess is that they're probably going to try to co-locate with their adult use soon enough. So the questions that I always get is, was this drop off anticipated? Was it kind of like the slow demise of the medical program? I hate to even say that, the dispensary model. Was this predicted? Was this anticipated? And why do we even need a medical program anymore? These are kind of the foundational questions that I always get asked. So was it anticipated? I think in 2020, the bill that created the Cannabis Board and the tax and regulate system certainly anticipated it. They knew that, the patient numbers were dropping. But you said here that it's still your intent to make sure the way that I read this, that the patients are held harmless. They still have continued access to the products and services that are only available by being a patient. You don't have to kind of prop up the existing structure, but you got to make sure the patients continue to have access. And then, do we still need a medical program? Well, here are the things that are offered on the medical side that really don't exist on the adult use side. First is privacy and confidentiality. All of the existing dispensaries, including historically, have either had a reservation system or some way where you would be the only one in the store to purchase if you wanted to kind of maintain your privacy or confidentiality. They are allowed to offer products that are prohibited on the adult use side, custom formulations, higher potency products. And then there's also this catch-all, any product approved by the CCB. So we've approved things like a transdermal patch that's not available on the adult use side, like tablets, pills. Access to specialty services. This is kind of the private consultation. You can kind of speak one-on-one with a bud tender about your medical history and kind of get some consultation from those folks. I mentioned the reservation system. They are allowed to do delivery, curbside pickup, and you also you can apply for a caregiver. So this is if you kind of can't get out of bed or, can't go to the dispensary or grow your own cannabis, a caregiver can do that on your behalf. And those people are registered with us as well. Minors, people under 21 can qualify as a medical patient. And then the medical patients also have increased possession. They can possess 2 ounces of cannabis at a time, as opposed to on the adult use side, 1 ounce. And they have some increased home grow allowances compared to what's legal for just regular adults in Vermont. And then the big one for a lot of folks is that it's tax free. So they're not, these sales aren't subject to the 14% excise tax, 6% sales tax. They're exempt from that. So this is what you did last year. You created a medical use endorsement. This isn't a terribly unique situation. Almost every adult use state allows medical use and adult use to co-locate. In fact, some states require that you have a medical side to your adult use shop. But we just, there's a lot of concerns about, is this going to turn into an end run around tax collection, an end run around potency caps? So you delayed the onset of this by a year. And then you kind of put some additional requirements for the medical use endorsement, including an enhanced training and educational requirements for the employees that interact with patients. And then you asked us to report back on a number of issues that may implicate this. So first, how do we improve patient and provider education? So, because of the their Schedule I status, cannabis really is not being taught as part of the core curriculum in medical school. There's a lot of internet research out there. I'll just put this slide up. This is from a patient survey that we did in 2023. This is how people are getting information about cannabis right now. They're talking to the people at the dispensary. They're doing self-guided research, meaning they're trying products and kind of seeing how they work. Are they effective? Should I try something else? Or they're going on the internet. They're talking to friends and family. A lot of doctors, because this is not legal federally, because there's potential insurance complications if doctors are kind of recommending cannabis or saying that cannabis has therapeutic effects or whatever else, kind of talking about drug interactions with cannabis. A lot of physicians and pharmacists won't even just talk about it with their patients. So this puts us in a difficult position because what patients are going to expect, what we see happening is patient walks into a adult use retailer that has one of these medical use endorsements, and they're going to say something along the lines of, I have multiple sclerosis. I'm on these 6 different medications. What is a good strain of cannabis or a good product to help me with my sleep? And you're putting kind of a bud tender in the position of having to, know what they can and cannot pay first. And second, you can see this kind of play out in any number of iterations. So how do we improve the education that's happening at that kind of point of sale? So what we recommended, and this is, I've spoken with kind of all of our other regulators around the country, how they deal with this problem. That kind of led me to actually a Vermonter who teaches at UVM Medical Graduate School, has a PhD in the kind of pharmacokinetics of cannabinoids. And she, in order to address this exact problem, created an app called Canify, where a consumer or someone who's cannabis curious enters some information about themselves, takes a questionnaire, how old are you? How much do you weigh? What's your height? What's your frequency of cannabis use? Are you pregnant or breastfeeding? Because then it kicks you out. Don't use cannabis. Do you have a history of schizophrenia? That's another screener question that kind of says cannabis has shown these correlations between early onset schizophrenia. And then what it does is it generates a report that is essentially kind of a meta-analysis of all of the existing kind of peer-reviewed studies that exist about what type of cannabis product would most likely deal with whatever issue you're requesting, whether that's pain or sleep or something else, nausea. So we've vetted this program through various committees, the Senate Health and Welfare, the Substance Misuse Prevention Advisory Council, the Vermont Department of Health. They all feel comfortable with this being a kind of medium in between a bud tender and a patient that's asking medical questions. And so we feel like this might be a useful tool in the toolbox for making sure that our bud tenders who are economically motivated are not kind of making recommendations about products to people that have, very serious health conditions.
So can I ask a question? This would be for use by the employees, or it would be for use by the individual seeking the cannabis?
It would be both. You could, a person could use this on their own time at home. It would be on the CCB's website, but it would also be when you kind of hit one of those threshold questions that kind of requires some medical knowledge, that conversation between the bud tender and the patient has to stop, and they have to use Canify in the store to kind of be the medium by which kind of relevant information is being transmitted. And I say relevant information, the Department of Health is going to help us kind of figure out all of the appropriate information that they want to see on there around cannabis use disorder, around cannabis hyperemesis syndrome, around kind of prevention services that are available in the state. It would be, the short answer is it would be both, and the information that will be generated will be vetted through the Department of Health.
And it could be used by the physician
Right,
also,
right.
right? And it could also, so you can print out your results and take it to your physician and have a conversation.
Okay, okay. So theoretically, you could be, sitting down at one of the dispensaries and going through, they could be saying, well, let's pull up this tool and let's start filling it out, and they could be going through that with you.
Right. The questionnaire itself has two versions. One that's geared towards someone with a medical background, someone with a kind of advanced degree, a doctor, healthcare professional, and then one that's kind of a little bit more basic, that's more digestible from someone, who doesn't have that kind of background.
Mm-hmm.
And I know that there's a response to us seeking one of these licenses for Canify from the Medical Society. They agree with the concept that we need to have a peer-reviewed, evidence-based kind of way of transmitting information to patients. What they don't like about this is there's one aspect to the kind of free version of Canify where it tells you kind of the basic kind of type of product that you should have. And then if you go one screen further, if you kind of say, show me my product matching score, it actually Canify has downloaded our entire product registration menu, all 4,000 or so products that are available in Vermont. And it gives you a matching score for each of those products based upon the report.
Mm-hmm.
We've specifically said that that's very likely an illegal advertisement. So we've said that in the state license version, you need to cut that functionality out so that it's not pointing you to a specific product, it's pointing to you kind of like the cannabinoid profile, like kind of the dose, mode of administration, CBD to THC ratio, and the kind of milligrams that you would want based upon the kind of information provided.
So what I'm hearing you say is that this application, you're able to customize this to what Vermont's laws and recommendations are, from our health department and stuff.
Right. And we really do not insert our opinions about cannabis into the information that's transmitted through the warning label or at the bud tender education. We have fully outsourced that to the Department of Health. They're the ones that, have the resources to know what's an effective message, what is important for the kind of overall prevention picture in the state. So they are involved with this project as well.
You're moving ahead with this, so it's a recommendation, but it seems like that you're taking action steps.
We have taken action steps mostly because we have to do something for this medical use endorsement. And if it doesn't include Canify, and if it's just a one-time education class with bud tenders, so be it. But I think that you're not going to be able to cover in a one-day class all of the various things that you cannot say about medical advice,
right,
and B, kind of the various scenarios that will likely play out.
I think it's an important point that you're making about the what do you call them, bud tenders?
Bud tenders.
That they're not medical professionals.
Right,
And so, you know, it's not logical that we'd be requiring them to acquire medical knowledge. But on the flip side of things, people are there asking questions about what's going to assist them. So, yeah, Representative.
Yeah, and likely, I mean, certainly understand the physician or pharmacist reticence and lack of knowledge. I'm just wondering, you know, the medical society had a number of other objections of it. You gave kind of very high level. And I'm wondering if you're moving ahead of this, how are you addressing or dealing with some of their other concerns? Is that something you're working through with them in a dialogue if you're working with us?
The person who started Canify, who's a professor at UVM, that teaches the cannabinoid class, has engaged with the medical society tremendously. I mean, it's an open dialogue. And so they are certainly in the conversation. We rely mostly on the Department of Health, not the medical society, but the medical society can certainly, through the Department of Health or elsewhere, with the kind of founder of Canify, you know, try to address their concerns. Certainly the product matching score is off the table. We've decided to eliminate on the free version, you can kind of create a user profile and kind of log the kind of products that you try and, you know, kind of take notes on them. We're eliminating that. So there's going to be no kind of data retention here. So
their concerns already may be, I mean, they might already not have the same perspective as their report says.
I think so. Yes. Yeah. I mean, the truth is, you know, when we first started looking at Canify, we were with the Dr. McLean from the academic detailing program at UVM, and his job is to evaluate the academic rigor. One of the job of that program is to evaluate the academic rigor of any topic, any report. And he said, listen, this is more important than ever on cannabis because there was a lot of kind of junk science out there. A lot of bias built into these reports are usually funded by cannabis companies. It would be a full-time job for the academic detailing. It would be at least 2 positions, I think he said, for us to do it there. So we've explored whether we could do it kind of through UVM first. But it was just kind of, it would cost too much money, I think, to really do it that way. And he has written testimony from last year to that effect. And they also objected us to creating a continuing medical education course on cannabinoids, but reuse the existing course at UVM where this person teaches, which is fine. The problem with that course is I think it's an 8-week course. And so what doctor can kind of just take off 8 weeks to go get, what we're looking for is a voluntary kind of continuing medical education. It could be a series, but it's not just an 8-week curriculum. And that may or may not be part of the kind of contract. We're still trying to negotiate, you know, what we can do.
Thank you.
Recommendation 2, this is kind of a continuous question that you guys are asked to resolve. The process for evaluating and improving new qualifying conditions. So, you know, we have about 13 qualifying conditions right now. They're mostly very, very serious, debilitating conditions, lifelong conditions. But you get asked to add new ones all the time. And it's really this committee that makes that decision, this committee and your counterparts in the Senate. And frankly, you know, how this generally plays out is you get handed a bunch of different reports that say conflicting things about the condition and the effectiveness of cannabis to treat it. You know, because this is a federally illegal substance and because, you know, these scientific reports have various level of academic rigor, you kind of find yourself like, what are we supposed to do here? And generally speaking, you know, you don't add new conditions because the science is all kind of like cutting edge and theoretical in a lot of instances. And yet, despite that, every year it comes back to you. And so what we recommended in the past, and this is either just put this in the hands of a treating physician. You know, the physician can kind of say, well, cannabis might help for you. I'll sign your card. You know, you have stage, well, whatever, the cannabis might help. So put this in the hands of the medical professionals or authorize a non-legislative entity to evaluate this and either recommend to this committee, after they've evaluated the science, or just give them the authority to do it on their own, just through rulemaking or whatever else. They can add new qualifying conditions. So I just have some context about how this works in other states. So states that have that non-legislative review, there's 12 of them. You can see that most of them run through the Department of Health. And I think that that is a logical place for this. They have the ability to do this well, to evaluate these types of questions. Some of them leave it with the Cannabis Regulatory Authority. However, I should say that I think some of those are embedded within the Department of Health as well. And I think Utah is the only one that kind of has just a group of kind of not just medical professionals, but caretakers and patients on there as well, kind of not like lay people. Yeah.
Do you happen to know among those, or how many of those you mentioned on the prior slide, some like recommend to the legislature versus directly say this should go on it?
I think I actually do have that information in a prior, but yes, there's a few of them. It's usually a petition process. So a person who's not a patient but has a condition petitions for a new condition to be added. In Minnesota, that triggers a review of the Department of Health, and they look at all the research that exists for that condition, whether cannabis can be effective treatment for that. And then they make that the Commissioner of Health makes the final call, but there's a year delay between the kind of final call being implemented. So the legislature has a veto on that. They've got one kind of year to veto whatever. And of course, I just have to mention here that, there's pretty significant tax implications for what is a qualifying condition and what's not. The one that kind of keeps coming up over and over again is chronic pain and anxiety. Those are the two conditions that most patients request. And, those are somewhat tricky. I am supposed to diagnose and maybe not, but, if all the kind of people with anxiety qualified for the medical program and didn't pay the 20% revenue. So this is a decision, it would have severe impacts on the revenue that's coming in. I'm not saying that that's a decision for or against, but it's just something, it's a reason why you may not want to just hand this over to a third party, because it will impact the revenues of the state.
Yeah, it's an interesting.
Well, the chronic pain, we already.
Sorry, acute pain, I meant, sorry.
Oh, okay.
Yeah, acute pain.
Acute versus chronic.
Right,
pain.
yes.
Yeah.
Yeah.
It's chronic pain we have. Yeah.
So, what I'm seeing is, between the two options that, the other options besides legislative approval, or in addition to 23 out of the 39 states do it in a delegatory way.
Right. So this is kind of a big one. I know that the kind of Green Mountain Patients Alliance, which is an advocacy group for patients and caregivers, would love to see this decision move out of the kind of politics of the building and kind of be, led by science. But then you just have to understand it's, the kind of other factors at play.
Well, and, to the point that you made early on, led by science is a little bit of a misnomer, given, some of the restrictions on the study and so I think, I guess the question comes down to, are we at that stage? When we were talking about this report, we were sort of comparing it to our PFAS discussions, and every year we add a new consumer product to the list, or a new array of consumer products to the list. And at what point are we going to, turn that over to a regulatory process? And we haven't made that decision yet. One, because it's expensive to do. And, are we at that point with cannabis for, medical relief? I think that's it's a question that we should be talking about. And I think that's, sort of the impetus for asking for more information and potential recommendations about this, because I think that we were recognizing that, we're sort of at that, feeling like we're sort of at that stage. And now that there's been some, we have some history with, the commercial use cannabis market and understanding a little bit more about what that might be like on an annual basis and impact that it's had on medical cannabis, and understanding more about the dual licenses and, how those are going to come to be. I think it's a question that we should debate and kind of come to a conclusion on, or at least the conclusion that is, for the time being. So, I think that I think it's worthy of us, maybe looking at a bill next year to have this sort of broader discussion about it, because you're right. There's the continuing advocacy, and and it's kind of it's a weird place to be about sort of putting that advocacy on the scale with state tax revenues, a significant percentage of which go to supporting our health department's programs on prevention. So this is what happens when you get into state taxation of products such as this. There's, I guess we have to be as sort of the arbiters of weighing those pluses and minuses at this point in time. But I think it's time for that conversation, I guess is what I'm saying.
And however I can support this committee in reaching that decision, we at the board are agnostic about this.
Yeah.
If you were to give it to us, we'd have a tough time really evaluating this. We're not really public health, we don't evaluate public health documents.
Yeah.
But.
And on the flip side, I'm not sure that that they haven't said anything, but I'm not sure that the health department is, well, they might have the expertise. I'm not sure they're in a position of desiring to do this. I don't know that for certain, just basing that on sort of their reaction to other things we've talked about.
Well, I can, when the time comes next year, whenever, maybe kind of flesh out how these other processes work. Like if it is, this compassionate use board in Utah, who are the appointing authorities? How many people is it? What interests do they represent? How does, is this a petition system in some of these other states? Is it rulemaking?
Yeah. I'm not, yeah. And we have in past, I guess the biennium is still young. It's only nearly half over. We don't have a bill on the wall this year about adding conditions, but that doesn't mean we won't have one. I just think it's important for us to have the conversation, talk to the health department, talk further with you, talk with other people who are interested in this, and figure out whether it's the time to be thinking about this done in a different way or not. I mean, people might come to the conclusion that we should still be doing the add on or add not process, but thank you. I appreciate the information about sort of what other states are doing, and where that's housed. That's
everyone is trying to tackle this issue, varying degrees of success. So recommendation 3, this really is kind of a cutting edge area of cannabis regulation. Is we're starting to get some real solid reports from Health Canada, who's legalized nationwide. And they have the full kind of resources of the federal government to kind of really research the outcomes. So they've started to kind of notice that they in California and New York have just been pulling kind of like random, both legal market vaping devices and cartridges, and also illicit market off the shelves and testing them, the kind of liquid and the vapor that's coming out of them after they've been ignited. And they're seeing that there is the presence of all sorts of stuff in them, but on the regulated side, it's mostly heavy metals above accepted tolerance levels. And so the theory is that the kind of chief components of them are cracking, breaking, and leaching heavy metals into the vaping liquid. And
Same is true for non-cannabis.
yes,
Yeah.
We have lots of testimony on that in the last biennium, and so this isn't surprising to me. I mean, this is present in the things that we are researching on the
yes.
non-cannabis side of things.
Not just
the use.
breaking, but also if they sit unused for a long time, the metals are leaching into the liquid.
Interesting. Yeah. Yeah.
And then one of the more unique problems with cannabis is that cannabis ignites the liquid at a higher temperature, so it has to reach an even higher temperature than to aerosolize tobacco. And so it's the increased risk of breaking and leaching at those higher temperatures.
And I mean, I don't know, I haven't seen data, but you know, what I see walking around is that there's a higher preference for use of this method than you know, other uses, you know, other methods of delivering. And but I'm not, you know, I think people believe that somebody somewhere has said that this is safe.
It's also discreet, and so I think parents are adults, so it's more discreet and therefore I think attractive in some ways.
Yeah, I think vapes, if I recall off the top of my head, make up between 20 and 25% of our cannabis market. So and you know, they've only been around really since 2013. So it's, you know, that's a tremendous uptake, and it probably will get more, probably capture more. So anyway, the question here was really, I raised this with the Senate Health and Welfare Committee last year, and they're like, well, what are you doing about it? I was like, well, I don't know what to do. No one's doing anything about this right now. Cannabis context. And then one other just concern beyond just the leaching is the batteries, the lithium ion batteries, which are usually encased and impossible to remove on most vaping devices. So they're getting ground up and thrown in the landfill. And so I know we have kind of you've asked the ANR Solid Waste District, or whatever it is, Solid Waste Department, to create a battery stewardship program and report back on how they're going to do this. So we want to, in conversation with them, we just want to align our battery requirements for these to be in line with the battery stewardship program once that kind of is more fleshed out.
And you know, I'm just looking at the recommendations, and I'm thinking about the implications for you know, the Vermont market, let's just say. What do you see other states doing with regard to these health concerns around the delivery methods?
There is almost, I think New Jersey is the only state that has something on this. And what they do is they have a maximum heat and voltage limits for the heating elements. So they can't stay on at that 400 degrees for any longer than just like a certain amount of time, and they can't go above that. And you know, whatever the kind of temperature is to aerosolize cannabis. And so they do kind of the maximum heat and voltage limits. And then they have a list of components that can't exist in the devices. We currently don't have any authority over devices. So that's why we didn't just go ahead and do some of this stuff. And we haven't done kind of an economic analysis as to what this would mean for the Vermont market if all of a sudden we're requiring just this one or two types of vape cartridges, and we have to replace or sell through all the existing ones.
Well, then there's the whole enforcement issue.
And the enticement. I mean, we don't want the illegal market. That's part of this, creating this. So if it's cheaper, easier on the illegal market, then it's not going to be productive.
Yeah, I mean, we faced this same conversation when we were talking about tobacco and, you know, how to deal with these health implications of these, not only the tobacco, but how you were ingesting it. So I'm not sure, to be honest with you, other than your recommendation around the battery, about what else that we can do as a state on this topic, right? You know, until, I mean, if we had, you know, 10 or 15 other states who had figured out a way to do this at much larger market, and so the manufacturers were more inclined to follow suit with trying to make changes. So I guess maybe it's a note to encourage other states, like California and New York and places.
Canada.
Right, a whole country, right? Because then it becomes much easier for a state like Vermont to tap into that. But we found the same to be true of our PFAS discussions. We have to kind of follow suit with some of the other larger states.
So that I think there's a bunch of attachments. That it's attachment A is just background on Canify and Dr. Klumpers, who's the founder of it. And then I think all of the named stakeholders, with the exception of the Department of Health, wanted written recommendations from them as part of this report. So those are included in the attachments as well.
Thank you very much. We appreciate that. And I think, we'll have some discussions about the, qualifying conditions and that whole discussion about sort of like, where do we go from here? And do we think about legislation next year to, make some changes to that? Are we at that point? Are we ready for that? And thank you for offering to be a resource as we take a look at that. I appreciate it.
Yeah, of course. That's how we came up with a lot of our regulations, was just looking at how all of the kind of 25 other states do things and what works for this size and kind of legislative goals and priorities of our market. So,
Great.
Yeah.
Thank you. Thank you so much for being here. Appreciate it. Nice to see you. We're happy to have Bryn here back.
We miss her. Yeah. Yeah. I mean, the thing that she was asked to do, which was turn the legislation into rules and the rules into action in a kind of very compressed timeline. It's just amazing.
Yeah. Okay, before people head off, I just have a couple of updates. So the first thing I want to do is to just congratulate Dan, because it kind of went off without much fanfare yesterday, but H13 is something that Dan and I both have been working on for, I can't tell you how many years. We were trying to figure it out this morning.
Since 17 or 18.
Yeah, and that, so it's on its way to the governor now, and hopefully he will sign it, but that is something that it's been something, this is the third time was the charm, hopefully, so knock on wood on that.
Sent it to the Senate a number of times and it just sat on the
That-
wall.
Yeah, so, good job, Dan.
Oh, good job. Thank you for helping. Good partnership. Get it moving for sure.
And then on the wanted to let people know that the health department had reached out to Representative Bloomley, and she reached out to Senator Lyons and to me about the substance use, what they called the campus, but thankfully they're not referring to as campus anymore. It was not in the House version of the budget, was not in the Senate version of the budget, as well as the aftercare coordinators for the residential treatment, again, not in either budget. So they were just honestly making their case for wanting that to get considered again. And I just wanted to let people know that conversation had happened. Nobody made any promises about doing anything, and sort of we were clear about some of the reasons why it didn't get elevated as a priority. One of the key ones being the recovery community wasn't really involved in understanding and making that recommendation. And two, that we are faced with the opioid abatement settlement fund in a, decreasing amount, it's not an increasing amount. And there are 4 ongoing programs there that have we've registered a commitment to, and not knowing what's happening at the federal level didn't seem the prudent time to be adding another program that we don't know if we can continue to support. So I just want people to be aware that they were trying again. They will probably continue to try, but that was a conversation. And then Esme represented us down in House Appropriations, and I understand they have a small amendment.
Yeah, a little bit. Yeah, I think they wanted further clarification about, they're really stuck on this piece, I think in section 1. About a childcare program that was about to open, but needed extraordinary funds, to do so pre-licensure, in the process of licensure. And what is this one? So just, I guess, further clarifying the language there.
Yeah, I don't have the language. She just, Rep. Shy just said that they're preparing an amendment, so.
Yeah.
And then we also have another amendment coming from Representative Holcomb. It's our year for amendments on quote unquote simple bills. So Representative Holcomb will be scheduled, we'll try to get her scheduled for, tomorrow, I think, maybe later today.
Which one is that one?
All on the same bill, 248.
Same,
okay. So we have to see if we can get, there's a couple of witnesses we'll need for that one, so it's a much broader amendment than,
So what's the amendment?
we'll hear about it. I don't have a final version of it yet.
Oh, okay.
But it's on 248. It's on the childcare bill, the technical amendment bill. So I just wanted to let people know that that was happening. So we may, depending upon schedule, we may have them come after floor today, or it might be tomorrow morning at some point. Since appropriations voted 248 out today, it'll be on notice calendar tomorrow. Theoretically, it'll be on the floor on Friday, but I think that that probably will be held up depending upon what Representative Holcomb does with her amendment, because her amendment impacts financial status of the Child Care Financial Assistance Program, and it would need to go to 3 other committees besides ours. So it is not likely, Esme, that we'll be reporting on 248 this week.
Yeah, I got the sense.
Yeah.
I was so ready on Tuesday.
I know.
On Tuesday, I'm like, let's go.
Warrants.
We should also make note, in case people didn't see it, that Representative Bishop's bill got a prominent play in final report.
Yes, final reading.
Final reading, right?
Yes.
And not to, suspect they, like we are, like, where are all the big
Bills.
issues? Where is the House floor? Well, we got nothing. Well, let's highlight this one.
Okay, so just wanted to let folks know that we're doing that. So then you will also see, some gaps in our agenda. That will be because we will be having reports on the remaining people who haven't reported on their reports.
Yep.
Okay, so we will be doing that. So have a nice lunch. We'll see you after floor. Thank you, Lori.